That is the clotting cascade. Males have an XY chromosomes and females have XX. Therefore, in an X-linked recessive disease, the males are clinically affected, whereas the females are not. Hemophilia is an X-linked recessive disease. Hemophilia A affects factor 8, Hemophilia B affects factor 9, and Hemophilia C affects factor 11. Usually, the patients with hemophilia present with intra-articular and retroperitoneal bleeding. The severity of the disease depends upon the level of the factor activity. A severe disease has less than 1% of factor activity level. A moderate disease is 1 to 5% of activity level, whereas 5 to 30% of activity level dictates a mild disease. When one would want to replace the factors, it depends again upon the degree of hemorrhage. For a mild hemorrhage, one would replace up to 40% of factor activity level. For severe hemorrhage, one would go up to 50%, whereas for life-threatening hemorrhages, one would replace the factors so that the levels reach 80 to 100%. Usually those people with hemophilia A are treated with factor 8, but remember that 20% of them develop antibodies to factor 8, therefore one would have to consider starting recombinant factor 8. Factor 11 deficiency or hemophilia C is a very interesting phenomenon where the patients affected are protected from thrombosis. At the same time, they have a minimal risk of bleeding. So the effect here is similar to using an anticoagulant. It is very rare to have deficiencies of factor 2, 5, 7, 10 and 13. Unless one knows the exact factor that is deficient, one can replace it. If not, the treatment is fresh frozen plasma. For most factor deficiencies, the treatment happens to be packed RBCs for the blood loss, fresh frozen plasma and platelets for replacement, and cryoprecipitate to replace the fibrinogen. Hypofibrinogenemia can occur after prostate surgery. It occurs because of the release of urokinase. The treatment is usually tranexamic acid or epsilon aminocaproic acid. Both of these act by preventing fibrinolysis. There are many reasons why a patient could have disseminated intravascular coagulation, wherein there could be excessive thrombin generation with diffuse microthrombi in the vascular tree. Remember that all the blood clots in the end are of stable fibrin clot, and the fibrin monomers form polymers. Thus there is a consumption of platelets and coagulation factors, and due to this there is diffuse bleeding. Investigation wise, there is an increased prothrombin time, a very low fibrinogen level, and an increased D-dimer level. The fibrin polymers break down to form dimers, wherein there are two molecules, and a molecule which takes polarized light to the right side is called the D-dimer. So now you know where it comes from. The treatment for DIC is FFP, platelets and cryoprecipitate. Fibrinogen concentrates may be given if cryoprecipitate is not available, and one should also add heparin. The traditional teaching was that the coagulopathy of trauma is caused by acidosis, hypothermia and dilution. This is not necessarily so, because immediately after trauma, 1/3 of the patients will have the coagulopathy of trauma. There are two mechanisms which act in opposite directions. The tissue injury activates the extrinsic system, therefore being a procoagulant, whereas the shock activates fibrinolysin and thrombomodulin, which then acts on protein C and S to inactivate factor 5 and 8, thus acting as an anticoagulant.